All right, chapter 9, the shoulder girdle. So let's start out by clarifying a couple of terms. So when we talk about the shoulder complex, we're talking about the whole thing. We're talking about the shoulder girdle and the shoulder joint together. Basically, the shoulder joint is just the glenohumeral joint. It's the pure shoulder joint, the pure glenohumeral joint, where we've got the head of the humerus articulating with the glenoid fossa. The shoulder girdle has to do much more with the scapula and how the scapula articulates with the rib cage. We also see the scapula attaching to the clavicle, and the clavicle in turn attaching to the sternum. All right, so we're looking at the scapula, clavicle, and sternum when we talk about the shoulder girdle, and the ribs for that matter. And the joints of the shoulder girdle, and I'm just going to give you abbreviations for now because we're going to get into the full names in a little while, so we don't need to get too tied up in details yet. The acromioclavicular, or AC, the sternoclavicular, the SC, and we'll call the scapulothoracic the ST. All right, so AC, SC, ST, and the shoulder joint is the glenohumeral joint. So that's how we differentiate the shoulder girdle from the shoulder joint. So basically, this lecture is about the shoulder girdle. So we're only going to be talking about the scapula, the clavicle, the sternum, the rib cage, and these three joints here. That's what this lecture is. The next one, all right, we're not going to get to the actual shoulder until the next lecture. All right, let's start with some bones and landmarks here. So most of these should be familiar to you, but I want to take the time to review them here. Starting with the scapula, we've got the superior and the inferior angle. So, and actually I'm going to jump down to the vertebral border, the third one. The vertebral border is the medial border of the scapula that faces the spine. If we go all the way to the top of that vertebral border, that's the superior angle. If we go all the way to the bottom of the vertebral border, that's the inferior angle. The axillary border shoots out laterally from the inferior angle. Right, that's the axillary border facing the axilla. The spine of the scapula is going to be this posterior ridge that projects out laterally. We've got the coracoid process, which is the anterior projection off of the scapula. The acromion process, the lateral projection that rises from the spine. So the spine projects out laterally, turns into the acromion process. And finally, the glenoid fossa, which is this hollow area here on the lateral aspect. When we get to lab this afternoon, the very first thing we're going to do, we take the first 15 minutes and you're going to get a set of bones that looks like this, and you're going to have this list in front of you, and you'll be able to find all of these landmarks on the bones yourself. All right, so this is an overview for you, and you'll have a chance to get your hands on them downstairs in a little while. All right, the cranium. Cranium is the skull, basically. And the landmark that we're interested in is the external occipital protuberance, which is this, some people call it the bump of knowledge or the inion. All right, so right here. So the traps are going to originate on the external occipital protuberance. So that's why they're listed here. Any bony landmark that serves as an attachment point for one of the scapular muscles is going to be on this list. All right, so this isn't a scapular landmark, but one of the scapular muscles attaches here. That's why we're reviewing that landmark now. All right, clavicle, we've got the sternal end, the acromial end, and the body. So the medial end is going to be the sternal end. The acromial end is going to be the lateral end, and the body is everything in between. And then finally, we've got the sternum. So we've got the manubrium being the superior portion, the body's in the middle, and the xiphoid process is the inferior projection. All right, so all review, right? Okay. All right. Resting position of the scapula. So as we look at the scapula from the posterior aspect, we see that it rests from about the second rib down to the seventh rib. Right? So this is more helpful in locating the level of rib than it is for locating the scapula. The scapula is pretty easy to palpate from the outside. You can tell where the inferior angle is. But your patient might be having a trigger point or some muscle spasm or a facet joint that's not moving properly. And you might be scratching your head saying, gosh, I'm not sure exactly what spinal level that is. But if you can find the inferior angle and say, well, that's going to be the 7th rib, and it's just over from that, then you can say it's, adjacent to the 7th thoracic vertebrae. So the scapula can serve as a landmark to benchmark where you're at along the spine. The other thing we look at as we observe the patient from the posterior view is that we should have about 2 to 3 inches from the spinous processes to the vertebral border of the scapula. Right? So about a 2 to 3 inch span here and about a 2 to 3 inch span over here. And we expect them to be relatively symmetrical. Right? Really, as human beings, we're not symmetrical creatures. I mean, most of us are lucky enough to have 2 arms and 2 legs, so we call ourselves pretty symmetrical, but when you start really looking at the details, yeah, we're not symmetrical at all. Right? All right, as we look at the scapula and how it rests on the rib cage, we look at what we call the plane of the scapula. We see that this red line represents the frontal plane. Everyone's oriented to the picture, by the way. This is a cut-through view looking straight down through the rib cage and the scapula. So this is the frontal plane. We learned about the frontal plane last week. It divides the body into front and back halves, right? So the scapula, or the plane of the scapula, is represented by this blue line. The scapula isn't sitting flat on the frontal plane, right? It's tipped forward about 30 degrees from the frontal plane. So that said, when the scapula moves on the rib cage, so here's frontal plane, right? Scapula is doing that. So when the scapula moves on the rib cage, does it want to move in the frontal plane? It wants to move in its natural plane of the scapula, which is 30 degrees forward of the frontal plane. So therefore, if I pick someone out in the hallway and said, wait, we're doing a little kinesiology experiment here, raise your arms up over your head. They're going to tend to do that. That's how they're going to raise their arms over the head. They're going to naturally select the plane of the scapula to raise their arms over the head. No one's going to do pure abduction, because to get into the frontal plane where pure abduction happens, I first have to retract my scapula. Now I can do pure abduction and kind of force myself into the frontal plane. But the more natural plane is to move in the plane of the scapula. Right, so we're going to see our patients selecting that plane as the plane they move in. That said, when we're doing therapeutic exercises with our patient, are we going to always force them to work in abduction, flexion? Wouldn't it be more important to train them to work where they're most functional? In the plane of the scapula. So a lot of the exercises we do with the upper extremity are going to be in the scapular plane, because that's the natural plane of the scapula, 30 degrees forward of the frontal plane. All right, shoulder girdle and scapular motions. So let's first distinguish between linear motions and angular motions of the shoulder girdle. So linear motions are ones that can happen all by themselves. Right? So for example, any of these 4 motions, scapular elevation, I can just sit here and say, I'm going to do scapular elevation. It can happen all by itself. Nothing else in the body has to move. Scapular elevation happens independent of anything else. Scapular depression, going back down, that happens independent as well. So definitionally, as we look at elevation, it's just that, all right? There's nothing really complex about the definition. Scapular elevation, straight up. Scapula moves straight up. Scapular depression, scapula moves straight down. It doesn't really move down a lot more past neutral. You can get it down a little bit past neutral, all right? But usually depression is just the return from the elevated position. Good morning. How are you? Workbooks. Oh, yeah. So why don't we get those out now? We didn't pile them up for you this morning. All right, so we're on our linear motions of the scapula. So we said from a definitional standpoint, scapular elevation straight up, scapular depression straight down. Next, we've got our protraction, retraction, which is synonymous with AB and adduction of the scapula. So when the scapula retracts, it moves back toward its posterior midline. And anything that's moving toward the midline, we call adduction. All right, so scapular retraction and adduction are synonymous with one another. Scapular protraction happens when the scapula moves away from the posterior midline. And anytime we move away from the midline, we call that abduction. All right, so protraction and abduction are synonymous with one another. Got it? You can't reach over that side of the desk, right? Yeah, you know what? We really don't say what plane it is. If I had to say what plane it was primarily moving in, I would say frontal plane. But by the time we get to protraction, the scapula is like curving around the shape of the rib cage, so we're getting pretty. By the end of protraction, we're getting pretty far away from the frontal plane. All right. So we're not really going to. They keep getting away from you. I get it. So go. So we're not really going to label a plane that those happen in. Mm-hmm. Yep. So protraction, retraction. Okay. All right. So those are linear motions. Pretty easy there. The angular motions. This is a rotatory motion around some fixed axis, right? As we know, that's what angular motion is. And with the angular motions of the scapula, they can't happen by themselves. The shoulder joint, the glenohumeral joint, has to be doing something in order to impose these angular motions on the scapula. All right, linear motions happen in isolation. They can just be scapular motions, but angular motions can't happen unless the glenohumeral joint does something first. And then the angular motion is a byproduct of the glenohumeral joint motion. So let's go over these, starting with our scapular upward rotation. So this is what scapular upward rotation looks like. Right? It's rotating upwards. If we wanted to actually describe it, so you can have a definition, we would say it's when the inferior angle moves away from the posterior midline. Inferior angle moves away from the posterior midline, and the glenoid fossa tips upward. All right, so that's how we define it. And then downward rotation is going to be just the opposite. It's when the inferior angle moves back down toward the posterior midline, and the glenoid fossa tips back downward. Glenoid fossa tips back downward. All right, so that's upward and downward rotation. And next we've got scapular tilt. Scapular tilt looks like this. It's when the superior angle moves forward or anteriorly. Superior angle moves forward or anteriorly, while the inferior angle moves posteriorly. Inferior angle moves posteriorly. That's a scapular tilt. So some examples of when we would see this is if the shoulder is in full hyperextension. So you're going to do a softball pitch. You're winding up for a softball pitch. Right? As the arm extends, we're going to have scapular tilt that happens automatically. And finally, scapular winging. And winging happens when the vertebral border lifts up off the rib cage. When the vertebral border lifts up off the rib cage. When we see winging at rest, and some people will just be sitting here at rest, and you look at the scapula, you can see right through their skin that the vertebral border is way off the rib cage. It's very obvious to see when someone has it. That indicates weakness in a certain muscle. It's the muscle that travels beneath the scapula, attaches to the vertebral border, and is supposed to hold it down. Anybody know what muscle that is? You're in the right anatomical region, but that's not the one that functions the best to hold it down. But that was a very good guess. Serratus anterior, yeah, is the one that's mostly charged with preventing winging. Serratus anterior. All right, and sometimes we naturally get a little bit of winging that happens with protraction. So as we're protracting and the scapula is zooming across the rib cage this way, sometimes the vertebral border lifts up a little bit. And a certain amount of that with motion can be considered normal. So here's kind of a hand drawing of what winging might look like. As I said, it's pretty obvious when you see it. We'll screen each other for it in lab this afternoon and see if anyone has any winging. And now we're going to move on and look at some companion motions. So this basically is looking at the angular motions of the scapula that I said really can't happen unless the glenohumeral joint's moving. And then we're going to pair them and say, all right, so what does the glenohumeral joint have to be doing to produce this angular motion at the scapula? So let's start with flexion. So when the shoulder joint does flexion, we're going to get upward rotation and protraction of the scapula. All right, so the humerus elevates, but the scapula is doing this. All right, upward rotation and a little bit of protraction as well. Extension is going to be the return from the flexed position, and we're going to see the scapula downwardly rotate and retract. Right. Hyperextension, that's where we get our scapular tilt. Abduction is going to give us pure upward rotation. Adduction, downward rotation, or returning to the anatomical position. With medial rotation or internal rotation, we're going to get some protraction. Scapula gets pulled around this way. With external rotation, we get retraction. This guy doesn't rotate very well, but as we do this, right, and you can feel it. If you do external rotation, you feel your scapula retracting together. And then horizontal AB and adduction, you guys can feel this one too. If you come up on the horizontal plane, do horizontal abduction. Scapula's doing what? Retraction. Horizontal adduction. Scapula's doing protraction, right? Okay. All right, so that's how they pair up. Now, before we move off this slide, I want to point out one thing. And that one pretty important thing is that there's only two of these motions here that get the arm overhead. Flexion and abduction are the only things that allow the arm to go up overhead, which is a really important functional motion for us to have. So what's the common denominator here for the scapular motion? The scapula needs to be able to upwardly rotate for the arm to go up overhead.
Could you demonstrate that again?
The upward rotation, yeah. So when we do flexion, we're going to get upward rotation. When we do abduction, we're going to get upward rotation. Right? So the scapula needs to be able to upwardly rotate in order to get the arm overhead. So that said, we're going to pick on upward rotation a little more. We're going to dissect that one a little more so that we understand the nature of how and when it can be limited, because we know that that's going to create big functional problems for our patients if they don't have it. So the characteristics of upward rotation are tied to something that we call scapulohumeral rhythm. And scapulohumeral rhythm is basically looking at the ratio of motion that's happening at the glenohumeral joint as compared to the rest of the scapular, or the scapula. We'll call it the scapula for now. All right, so basically here's what happens between 0 and 30 degrees of shoulder elevation. And let me define elevation for you now. Elevation is basically anything that gets the arm overhead. It could be flexion, that gets the arm overhead. It could be abduction in the pure frontal plane. That gets the arm overhead. That's elevation. It's a form of elevation. It could be elevating in the plane of the scapula, 30 degrees forward of the frontal plane, or it could be anything in between. Right? So anything between flexion and abduction, right? Anywhere in here, as I'm lifting up overhead, it's all elevation. All right, so this scapulohumeral rhythm applies to all forms of elevation, flexion, abduction, and everything in between. And what happens is from 0 to 30 degrees of humeral elevation. So here's a 90-degree angle, you all agree? That's about a 45-degree angle, half of the 90. So 30's about here, right? All right, so from 0 to 30, all of the motion's happening at the glenohumeral joint, meaning the scapula is not upwardly rotating yet. From 0 to 30, pure glenohumeral joint motion. Scapula has not moved yet from 0 to 30. From 30 degrees all the way up to 180, lifting all the way overhead, that's when the scapula kicks in. And what we see is for every 2 degrees of humeral elevation, we get 1 degree of scapular upward rotation. For every 2 degrees of humeral elevation, we get 1 degree of scapular upward rotation. All right, so from 30 to 180, for every 2 degrees of humeral elevation, we get 1 degree of scapular upward rotation. So that said, that 2-to-1 ratio, who's doing more of the motion, glenohumeral joint or the scapulothoracic joint where the scapula is moving? Glenohumeral joint's doing 2/3 of it, right? And the scapula is doing the other 1/3? Okay. And from 0 to 30, it should just be the glenohumeral joint, no scapular motion. So what do you think might happen if the glenohumeral joint wasn't moving properly, though? As in the case of frozen shoulder syndrome, medical diagnosis for that is adhesive capsulitis. Right? So if someone had a frozen shoulder or an adhesive capsulitis, and the glenohumeral joint was kind of stuck and not moving well, and the patient was trying to get their arm overhead, if the glenohumeral joint couldn't do the pure motion from 0 to 30 and couldn't carry 2/3 of the motion from the rest of the way up, then what might we see the scapula do to compensate? Less or more motion from the scapula? More motion from the scapula. So what we might see is from 0 to 30, we might be kind of palpating the inferior angle here. We don't expect to feel the scapula moving, but we might have a situation where as soon as the humor starts moving, boom, the scapula just gets pulled right into it. And that might be an indication the glenohumeral joint's not doing its job. So the scapula said, oh, I can help with that. But there's only so much motion the scapula has. It's going to run out of motion. So the patient will say, yeah, there you go. That's how I elevate my shoulder. It's all scapula. And the glenohumeral joint really didn't do anything, but that's as high as they can get then. Okay? So we'll talk more about that in lab this afternoon as we're screening for frozen shoulder and some of the compensations that we see. All right, let's talk about some of the joints contributing to scapular upward rotation. Again, just list them briefly right now, and what we're doing next is we're going to delve in more deeply and describe the anatomy of each of these joints. But the first one that needs to move is the scapula needs to slide on the rib cage. That's the scapulothoracic joint. All right, so we need motion at the scapulothoracic joint. And we'll call that the ST. All right, the next thing that we need so as the scapula is upwardly rotating, let's think now about the pivot point. So it's got to rotate on something. It's rotating on the clavicle, isn't it, while it rotates upward. So this is the acromioclavicular joint. So we need proper motion at the acromioclavicular joint also. Or the AC. And then finally, the last thing that's happening, and again, we'll discuss this in more detail in just a little bit, is as we're elevating, the clavicle, I'm really exaggerating now so you can see it, but the clavicle's lifting up. The clavicle's doing this. So the clavicle's doing this during upward rotation. So where is that pivoting from? That's pivoting from the sternoclavicular joint. Right, so we also need normal motion at the sternoclavicular joint. Or the SC joint. All right, so basically now we're thinking to get the arm overhead, the glenohumeral joint needs to have full motion, as well as these three areas need to be functioning properly. So it's not a simple order of business when a patient comes in and says, oh yeah, I really can't lift my arm over my head. It could be that problem could be stemming from a lot of different places. Maybe it's not even one of the joints, maybe it's just muscle weakness. If you rule out muscle weakness, next you have to go down the line and check each one of these joints and see if each one is moving properly to allow the normal amount of elevation overhead and the normal amount of scapular upward rotation. All right, any questions here? All right, so we're going to go through the individual joints now. First one's easy. It's the scapulothoracic joint. There's really not a lot to say about it. And it's true, even though we call it a joint, it's technically more of an articulation than it is a joint. It's not a synovial joint. There's no synovial fluid. There's no capsule involved. We simply have the anterior aspect of the scapula articulating with the posterior aspect of the rib cage. Right? The anterior scapula articulating with the posterior rib cage. And the two should slide on one another, and that forms the scapulothoracic articulation. All right, so not a lot to say about that. But we'll make up for it with the sternoclavicular joint. All right, so the sternoclavicular joint is where the sternum and the clavicle meet. So it's the medial end of the clavicle articulating with the manubrium of the sternum. So those are the joint characteristics. Medial end of the clavicle articulating with the manubrium of the sternum. So this is a plane-shaped synovial joint, and it's got a pretty strong joint capsule. So it's rare that it dislocates. There's also a little bit of an articular disc. I don't have a picture of that, but there is a little disc that resides between the medial end of the clavicle and the manubrium. So, we've got an indicator as to where the disc is here, but it's not terribly obvious in the picture. So the disc is handy. It actually functions as a little shock absorber. So if we fall on an outstretched arm and we use our arm to break our fall, right, the force goes up the arm, and ultimately it kind of ends at that SC joint, and the articular disc can absorb some of that shock. So now we need to talk about joint movements. So now I'll warn you that this is an exception to our usual rule. So usually when we have a plane-shaped synovial joint, the only thing we're going to say is, yep, it does a little bit of gliding and sliding, and that's it. But this is an exception to that, right? So we're actually going to be talking about 3 different planes of motion that the SC joint moves through. So I've kind of demonstrated them to you already. But the first one's clavicular elevation and depression, which looks like this, right? We said that this is a motion that happens when we're elevating the arm, right? This clavicular elevation depression. What plane of motion would you say this is happening in? More frontal plane. Yeah, so it's pretty close to the frontal plane. Clavicular protraction and retraction. So these happen with scapular protraction and retraction. When the scapula retracts, let's say, and it comes back this way, the clavicle's attached to it. The clavicle has to come along for the ride, right? So clavicular retraction looks like that, and protraction looks like that. So when the scapula protracts, so does the clavicle. What plane of motion does this look like to you? It's like transverse plane motion. All Yep. And then finally, clavicular rotations. So we're going to see a little bit of long axis rotation of the clavicle that looks like this. All right, so as we're doing a scapular tilt, let's say, and coming back this way, all right, we're going to see a little bit of rotation of the clavicle. All right, so all of those motions need to take place for the SC joint to be moving properly. So let me say one other thing here. So here we're talking about clavicular motions, but this is the SC joint. So there's two bones that comprise the sternoclavicular joint. It's the sternum and the clavicle. So I just want to point out to you that which one of those two bones is more movable? The clavicle is more movable. So that's why we're labeling the motions in terms of what the clavicle does. Because it's usually the clavicle that's moving. The sternum is locked in here. It's not moving. What's that?
That's the more medial.
It's the more proximal and more stable bone in this case. Yep. Mm-hmm.
You say the clavicular rotation happens with scapular upward and downward rotation?
No, the rotations are going to happen with a tilt. Yep. So when we do a scapular tilt back this way, the clavicle rotates. Yep. All right, we've got a couple ligaments to talk about. We've first got the anterior and posterior SC ligaments. So these are pretty easy. They just run from the sternum to the clavicle on both the anterior aspect of the joint. And if we were to flip it over and look at the posterior side, it would look exactly the same. So they simply reinforce the joint capsule and make it a little stronger. We've got the costoclavicular ligament. Costo means rib, right? And the rib that's the closest to the clavicle is the first rib. Rib number 1, it rests right under the clavicle. Right, so the costoclavicular ligament attaches the clavicle and holds it down, bands it down to the first rib. So I'm going to pretend this is a big clavicle for a minute now here. So what it prevents is it prevents excessive clavicular elevation. So there's only so far it can go up before the costoclavicular ligament limits further motion. And then finally, the interclavicular ligament runs from the clavicle on the right side over to the clavicle on the left side. So it spans across the top of the manubrium. And its job is to prevent excessive clavicular depression. So you can see if both clavicles were to fall down at the same time, that ligament would become bowstrung across the top of the sternum. All right, it would lengthen out and become bowstrung across the top of the sternum. So it limits excessive clavicular depression. All right, that wraps up the SC joint. Any questions there? All right, on to the acromioclavicular joint. Joint characteristics here. So acromioclavicular, so that's going to be between the acromion process of the scapula and the lateral end of the clavicle. Acromion process of the scapula to the lateral end of the clavicle. This is also a plane-shaped synovial joint. And this one has a weaker joint capsule. So the joint capsule here is much weaker than it was at the SC. So we see a lot more shoulder separations here. When you hear the term shoulder separation, it's not referring to the glenohumeral joint. A shoulder separation happens at the AC joint here. And what happens if it's separated, meaning the ligaments are disrupted between these two bones, if you look at the scapula, the clavicle is its only direct union back to the trunk. So if you break the attachment point here, the scapula is going to just fall right out. So what you're left with is this knob of a clavicle kind of sticking out here. And without the acromion process abutting up to it, it looks like there's this really funny knob sticking off the end of the shoulder. All right. So joint characteristics. So it has a weak joint capsule. Joint movements. So we are going to, again, we're starting out with two exceptions to our rule. Plane-shaped synovial joint, normally we'd say, it glides and slides along, we'd leave it there. but this is an exception again, and we are going to name 3 different motions that happens at the AC joint. So now we're looking at the scapula versus the clavicle. In comparing those 2 bones, which one is more movable? Scapula is more movable than the clavicle, right? So now as we're naming motions at the AC joint, we're going to say, okay, well, what's the scapula doing? And you know these motions already. We've already talked about them. So we look at upward and downward rotation, right? That's pivoting at the AC joint. When we talk about winging, that's also pivoting at the AC joint. And when we're talking about tipping, that's the same as a scapular tilt. It's another word for a tilt. It's also pivoting at the AC joint. Right, so all those scapular motions we talked about earlier, really all stemming from here. All right, a couple ligaments that we need to talk about. The superior and inferior acromioclavicular ligaments. It's a mouthful, but the name tells you exactly where it is. Superior acromioclavicular. From the acromion to the clavicle on the superior aspect. Right, inferior acromioclavicular, same thing but found on the inferior aspect. So these AC ligaments are simply there to help reinforce the weak joint capsule. All right, next we've got the coracoclavicular ligament. So coraco, obviously that's going to be the coracoid process, right? And up to the clavicle. So you'll see there's 2 portions to it. They both function like the same ligament, so we're just going to refer to it functionally as one coracoclavicular ligament. Don't worry about the different portions. So remember how we said the scapula is not attached to the trunk by much, right? We've got that little attachment through the clavicle back to the trunk. Well, the coracoclavicular ligament is kind of another way that the scapula hangs in place. It's like it's suspended from the clavicle. So it allows the scapula, coracoid process is on the scapula, allows the scapula to be suspended from the clavicle. So it helps to hold it in place. And finally, we've got the coracoacromial ligament, which runs from the coracoid process to the acromion process. So the name tells us that, right? Coracoacromial. But the coracoid process is on what bone? The scapula. The acromion process is on what bone? Also the scapula. So this ligament connects the scapula to the scapula. So that doesn't usually happen. We're usually connecting one bone to another to hold them stable, right? Not the case here. So this ligament doesn't have a stabilizing function like our other ligaments. What it's there for is it's there to serve as a roof over the head of the humerus. So head of the humerus is found in here, right? So, and the coracoacromial ligament serves as a roof. So we know that the head of the humerus needs to spin inside the glenoid, but sometimes, by accident, it can translate superiorly too far. And if it does, it's got this nice soft roof up top, the coracoacromial ligament, to help to contain it. Although too much of that is not going to go well for the body. And when we get to the glenohumeral joint lecture, what you're going to see is we've actually got a whole nother structure in here. Anybody know what? Well, a couple of other structures in here. Anybody know what they are? What also runs through this space? We're jumping ahead, but that's all right. We'll preview. Got the subacromial bursa in here. So if the head of the humerus does too much of this, right? Yeah, it's nice we've got this soft roof, but the bursa is going to be taking the brunt of that again and again. We're going to get a bursitis, right? We've also got the tendons of the rotator cuff, specifically supraspinatus. It's kind of right in that path running through here also. So supraspinatus is also subject to compression if we have too much of that superior translation. But nonetheless, if it happens once in a while, we've got this nice coracoacromial ligament to act as a restraint for the head of the humerus. All right, how are we doing so far? Hanging in? All right, so we're going to move on to the shoulder girdle muscles now. You guys need a stretch break before we do that? No? You good? All right. All right, so we'll go through muscles, then we'll break before we get to the next lecture. All right, the trapezius muscles. So here's where you printed out a separate muscle handout for this lecture, correct? Okay, so now you're going to switch over to the muscle handout and follow along with the individual muscles. So the trapezius, we break it down into 3 functional muscle groups, the upper, middle, and the lower trapezius. However, anatomically, it's one muscle. It's one big fan of muscle. There's no break between the upper, middle, and lower. When we go to the anatomy lab later this semester, you'll see that it's one big fan of trapezius, all right? But functionally, we break it down based on which portion of fibers are contributing to what specific motion. All right, the origin for the upper trap is the external occipital protuberance and the ligamentum nuchae, which is the ligament that connects the cervical spinous processes together. The insertion is the lateral third of the clavicle and the acromion process. So as we look at the upper trap and we look at it pulling on the lateral third of the clavicle and the acromion, we see a couple of actions are going to take place. So mainly the line of pull is going up. So we're definitely going to see scapular elevation when the upper trap contracts and pulls straight up. The other thing we're going to see is this, we pull up on, let's just pick on the acromion for right now. If I pull up on the acromion, and I want you to pretend that the axis of rotation is right where you see this bolt going through here. If I pull up here, am I going to get upward rotation or downward rotation? That's the pivot point. I'm pulling up here. I'm going to get upward rotation. All right, so upper trap is going to do elevation and upward rotation. Innervation, the spinal accessory nerve, that's that cranial nerve 11 that we just talked about a little while ago. And don't worry about memorizing the sensory component. You get enough to memorize with the motor component. All right, so here's the upper trap. You can see the upper trap pulling up on the scapula, performing elevation. And now we see it pulling up on the acromion and giving us some upward rotation as well. All right, middle trap. Origin, spinous processes, T7 through T3, coming across to the scapular spine. As the scapular spine gets pulled back in toward the origin, line of pull's going straight that way, we're going to get scapular retraction. All right, so that's the only motion there. So it's a pretty pure line of pull, so we're going to be purely with that one motion. All right, innervation, again, spinal accessory nerve, cranial, which is cranial nerve number 11. And again, don't worry about the sensory component. And here's the middle trap, right there, performing retraction. In these videos, when the muscle turns green, that's when it's firing. All right. One more time. So that's middle trap performing retraction. All right, lower trapezius originating on the spinous processes, T4 down to T12, inserting here on the root of the spine of the scapula. So for this one, I'm going from here up to here. Line of pull is pretty much straight downwards, right? I mean, a little bit of an angle, but mainly down. So we're definitely going to get depression, right? Because line of pull is pulling down. So the scapula's got to move down. In terms of rotation, picture this as the pivot point again, this bolt. So as I'm taking the root of the spine of the scapula, right here, and I'm pulling that down, what kind of rotation do I get? Upward rotation. All right? So we're going to get scapular depression and upward rotation. All right, and you'll see again, it's all trapped, so innervation is going to be the same as it was for the other two portions. All right, and here's our lower trap, performing scapular depression. Uh-oh. Never good when that starts. Sometimes the videos jam up the processor and the computer. Doesn't like all that video. There's short video clips, though. It really shouldn't be a problem, but it's not uncommon that it is. Let's see if we can pick up with lower trap, upward rotation. All right, so we see the lower trap here, and my remote. And yeah, when it's firing, it's giving us that upward rotation. So it's pulling down, and we get the upward rotation of the scapula. All right, some other scapular muscles. So we've got levator scapula. This one's pretty easy. The name tells you what it does, first of all. Levator scapula. It lifts the scapula, scapular elevations. You already got that much down in terms of the action. Origin, transverse processes of C1 through C4. The insertion point is going to be the vertebral border between the root of the spine and the superior angle. So this blue line right here. So as we lift up, and I'm just going to call it the superior angle region for now, all right, because it's so close. As we lift up on this superior angle region, we're clearly going to get elevation. From a rotational standpoint, here's the axis of rotation, and I'm lifting up right here. What's happening to the scapula? Upward or downward rotation? Yes, I lift up here on this point. Really, it doesn't move. I can't make it move, so you just have to visualize it. So I lift up here. That's the pivot point. Scapula is going to rotate in a downward direction, downward rotation. Right? So elevation and downward rotation are going to be the two actions for levator scapula. The innervation, cervical nerves 3 and 4, because right where these spinal nerves come out, before they ever get to, actually these two aren't even in the brachial plexus, or they're in the cervical plexus, but before they ever get to the cervical plexus, they pierce little portions of the levator. And also the dorsal scapular nerve, which was one of those little ones that branched off early from the brachial plexus. You do not need to memorize, when we have a mixed peripheral nerve name, you don't need to memorize the segmental innervation. You don't need to memorize that dorsal scapular nerve is a C5 innervation. Later on in your programs, when you get to your neuro class, you might need to start applying some of that information, but for now, it's all in your book. You can go back there and look. For now, knowing the name of the nerve is enough, okay? All right, so here's levator scapula right here, clearly lifting right up on the scapula, and here it is firing now, giving us downward rotation. One more time on that. So now it's firing now, giving us downward rotation. All right, so I'm going to play that one more time, and what we'll look at now, let's kind of look on the left side also here, and we see the upper trap and lower trap performing upward rotation over here on the left. You see them doing upward rotation? And then when it comes time to downwardly rotate, levator kicks in. So it kicks in opposite from upper and lower trap, upward rotation, then levator does the downward rotation. Upper and lower trap, upward rotation, levator, downward rotation. All right. The way these pictures, videos are set up, the left side's the superficial muscles, the right side are the deeper muscles. So the right side has all the superficial muscles, like the traps are resected, they're removed, and we're looking at a deeper layer on the right side. Okay. All right, rhomboids. So we've got a major and a minor. We're going to group them together because they function the same way. The origin are on the spinous processes of C7 through T5. And the insertion is the vertebral border between the inferior angle and the root of the spine. All right, so they kind of run on a 45-degree angle like this. So clearly we're going to get a retraction component, right? So rhomboids are going to pull in toward the spine. In terms of, I'm going the wrong way. So in terms of elevation, depression, we've got more of an upward line of pull. So we're going to get some elevation component from this. And in terms of rotation, if I'm going to take the vertebral border and I'm going to pull it up this way, and that's my pivot point right here, what kind of rotation am I getting? I'm getting downward rotation. Right? So elevation, retraction, downward rotation. Innervation, dorsal scapular nerve, again, that little branch off early from the brachial plexus. So here's our rhomboids doing retraction. So now we can appreciate, we just looked at middle traps doing retraction just a couple videos ago. So here's middle traps doing retraction now, turning green. The rhomboids are a deeper muscle, so we're viewing them on the right side of the screen. So the superficial middle trap and the deeper rhomboids, all firing at the same time. Middle traps, rhomboids, all working together to create retraction. Okay, one more time. Middle traps, rhomboids. Okay? Downward rotation. So now we're looking at the rhomboids working in concert with the levator. We looked at this video a couple times before. We looked at levator pulling the scapula into downward rotation. Now we see the rhomboids. They're doing the same thing that levator is. They're pulling on a different point of the scapula in a little bit different direction, but yet they're both contributing toward downward rotation of the scapula. Right? We call that a force couple, right? Multiple forces working on different points of the same object, creating a turning force. Serratus anterior, origin, lateral surface of ribs 1 through 8. Insertion, anterior surface of the scapula along the vertebral border. So kind of try and thread it through here like this. Right, so it actually passes between the scapula and the rib cage. I just can't thread the band right through there, but it looks something like that. So as the serratus pulls the vertebral border toward the origin here on the ribs, can you see how the scapula is going to move in that direction? I'll put it on the outside for a second, but realize that it really is tucked under here, okay? So as the serratus contracts, can you see how it's going to pull the scapula forward? It's going to pull it into protraction. So that's what it's a prime mover for. It's also going to do a little bit of upward rotation as we swing the vertebral border kind of to the lower portion of the vertebral border this way, and that's the pivot point. It will result in a turning force into upward rotation. And serratus is also the muscle that's known to prevent winging because it attaches to this vertebral border on the anterior surface. So it holds the vertebral border down. When this muscle's weak, we sometimes see winging of the scapula. So its job is to prevent winging. Innervation, the long thoracic nerve, right, which kind of drops right down here. So here's the serratus right here. So contracting when it turns green, pulling the scapula forward into protraction. So you can kind of look here now in this video, you see the serratus protracting. You can look back here, see middle trap and rhomboids retracting. All right, serratus is protracting, middle trap, rhomboids are retracting. One more time. So they're antagonists to one another. The serratus, as compared to middle traps and rhomboids, are antagonists. They do opposite motions from one another. And here's serratus doing upward rotation. So this video kind of makes it a little more clear than looking at the model. Sometimes we're pulling on the lower portion of the vertebral border. That's what's going to create that upward rotation. And now, as you look, remember we had the upper trap pulling into upward rotation. We had the lower trap pulling into upward rotation. And now we see the serratus pulling into upward rotation. Those three muscles together, upper trap, middle trap, serratus, all form the force couple for upward rotation of the scapula. All right. Pec minor. So pec minor originates on the anterior surface of ribs 3 through 5, and then it runs up to the coracoid process. All right, so as we look at the line of pull, as the coracoid gets pulled down toward the ribs, we're clearly going to get depression of the scapula. If we're thinking about it from a protraction-retraction standpoint, we've got the coracoid getting pulled around to the front. That's going to be protraction, going to create protraction of the scapula. And from a rotational standpoint, here's my pivot point. If I pull down on the coracoid, what kind of rotation is that? Downward rotation. All right, so I'm going to get protraction, I'm going to get downward rotation, and I'm going to get scapular depression from pec minor. Innervation is the medial pectoral nerve. And here's the pec minor pulling straight down into depression, so that's an easy one to see. And it fires and shortens and pulls down. And here's scapular protraction, where the coracoid's getting pulled forward toward the ribs. And here is the pec minor helping with downward rotation. So after elevation, it grabs the coracoid and pulls it back down. All right, so while we're on the topic of pec minor, we want to talk about the postural influence of this muscle. So with poor posture, meaning forward head, rounded shoulder posture, that common poor posture presentation that we see in the clinic, we know we're going to get short and tight pecs. So specifically, pec minor gets short and tight. It adaptively shortens. So before we can just say to our patient, okay, stand up tall, right? Just fix your posture and hold yourself like this. If the pecs literally adaptively shorten, it's going to take a lot of work to lengthen it back out again before the patient's able to get back into that correct posture. And pec minor is a really tough muscle to stretch on your own. So that's one muscle that I'll take the time to do manual stretching with on my patients. I'll keep a hand on the sternum and put another hand on the coracoid region, right? And try and separate those two attachment points. And that's how we stretch a muscle, right? Is to separate the two attachment points. A good home stretch for pec minor for anyone who has poor posture. It's tough to do a good home stretch for this muscle, but here's the objective. I'm going to show you a wall stretch where we try and pin the coracoid against the wall and then move the rib cage away from the coracoid. Because you can see how if the coracoid was stable and we moved the rib cage away from it, that it would lengthen the muscle. So what we have our patient do is to come over here to the wall. Let's say it's my right pec minor that's tight. I'm going to try and pin my coracoid process up against the wall. And then I'm going to rotate my body away from the coracoid. So I've moved my ribs away from the coracoid. All right, and that's an effective stretch for pec minor that someone can actually do on their own. All right, that's a tough muscle to get to. Just doing this isn't really going to stretch the muscle enough to make a difference in poor posture after it's adaptively shortened.
I don't know if this is pec minor or major, but when you come up to like the corner of the wall like that and you have your arm on it, and you do this
Like the doorway stretch, yeah. That's also a pretty good stretch for pec minor, but not as strong a stretch as the wall stretch. Okay. All right. So a couple pictures on muscle layering. We looked at some of this already in the muscle videos, but the superficial muscle is going to be the traps, upper, middle, lower trap. If we resect that superficial layer, then we look over here to the right side and we see the deeper muscles. What muscle is this one? Levator and rhomboids, right? So they're going to be the deeper muscles that are beneath the traps. On the anterior side, we see the pec minor, and we see the little interdigitations of the serratus anterior. And from a lateral aspect, we see an awful lot of superficial muscles that are shoulder joint muscles that we haven't talked about yet. It's in the next lecture. And the only one we see from a lateral side that's a scapular muscle are these little, again, interdigitations of the serratus anterior. All right, reviewing force couples. So we reviewed these when we looked at the videos. We looked at the force couple of the upper trap, lower trap, serratus, all pulling on different points of the scapula to create upward rotation. Here it is again. All right, upper trap, lower trap, serratus, all creating upward rotation. And then we also have the force couple for downward rotation, levator scapula, rhomboids, and pec minor. Right, all pulling on different points of the scapula in different directions, but all contributing toward that same downward rotation movement. All right, we need to talk about a couple of common reversal of muscle actions for the shoulder muscles. So upper trap, we just said upper trap does scapular elevation, right? Right, and it does. But what if the scapula or the scapulae were fixed and upper trap contracted instead? And yeah, so now it's also going to depend if we're talking about one upper trap or both of them. So let's talk about both of them for a second here. If the scapula can't come up toward the cranium, then the cranium's going to get pulled down toward the scapula, right? So we're going to pull into extension. That would be reversal of muscle action. If it's just one upper trap, right, and the scapula is fixed and won't come up, then we're going to get, as we pull on the external occipital protuberance, we're going to get a side bending and a rotational kind of a motion. All right, in terms of lower trap, so here's a time when lower trap is going to be active during function, during crutch walking, when it reverses its muscle action. So we normally think about lower trap doing scapular depression and upward rotation. But if the scapula can't move, let's say because there's a crutch fixed under it, right, forcing it in place, then instead of the scapula moving down toward the thoracic spine lifts up toward the scapula. That's exactly what we need to do when we're on crutches. We need to lift the body up over the scapula, all right, with crutch walking. So here, the crutch is the force that's fixing the scapula, and the lower trap pulls the thorax up toward the fixed scapula. As it pulls the thorax up, it elevates the body, and that's where we swing through the crutches. Right? The pec minor contributes toward the same thing. So pec minor lifts ribs 3 through 5, again, up toward the fixed scapula, also helping to elevate the trunk and allow the body to swing through the crutches. So can you think of two muscle groups that are going to be really sore when someone starts walking with crutches? Pec minor and lower trap. So you can tell your patient as you're teaching them how to use crutches that you can expect to feel some soreness in the muscles in the front and back of your shoulder. The patient doesn't need to know the exact name of the muscles, and tell them that's going to be perfectly normal because you don't normally use these muscles to lift your body weight, but with the crutches you will be. Because you understand that these muscles are reversing their muscle action, and instead of just lifting an arm, now they're trying to lift the whole body weight. Right? So yeah, they're definitely going to be sore when someone starts crutch walking. All right, and levator scapula. So in terms of levator, we think about levator lifting the scapula up toward the transverse processes of the vertebrae, of the upper cervical vertebrae. But if the scapula is fixed and the vertebrae get pulled down toward the scapula instead, what motion am I going to get? I'm going to get side bending. Right, so when levator reverses its muscle action, instead of scapular elevation, we get cervical side bending. All right, any questions? All right. All right, why don't you guys take 5 then. When you come back, we'll start the shoulder joint.